welcome you here for this Alumni College Every Union session on making better orthopedic implants, 30 years of collaboration in engineering and medicine at Dartmouth. For those of you who heard me speak on other occasions, you know that this broad area of engineering and medicine is one of just two areas of focused program growth here at the Thayer School. And by program growth, I mean research growth, faculty hiring, and educational growth, the development of new courses and opportunities for our students. And it really is engineering in medicine. We chose that name very deliberately and intentionally to signify the partnership of this engineering activity with our colleagues in the medical school. And I think there's no better representation of that partnership than the collaboration that our speakers today, John and Michael, have had for many, many years. John Collier is the Myron Tribus Professor of Engineering Innovation here at the Thayer School of Engineering. He is one of our most talented instructors as well as researchers. John teaches many of the design courses in our curriculum, particularly the course in many ways is iconic for the engineering education at the undergraduate level, NG 21, Introduction to Engineering Design course. John, as those of you who know him know well, has a bit of an association with Dartmouth and Thayer through the years. John has 4 degrees from Dartmouth. Not many people can claim that. An AB, a BE, a master's degree, and a doctorate from Dartmouth and the Thayer School of Engineering. Michael Mayer is the William N. and Bessie Allen Professor of Orthopedic Surgery at the Dartmouth Medical School. And he's a Professor Emeritus of Surgery at the Dartmouth Hitchcock Medical Center and an Adjunct Professor of Engineering. And again, I think this goes to the strong collaboration between the schools. Michael only has 2 degrees, alas. One of them a medical degree, the more important degree perhaps being an undergraduate degree in engineering from another Ivy League school. Okay. So without further ado, let me turn the program over to our 2 speakers. This event this morning is sponsored jointly by the Engineering School and the Medical School. My colleague, Dean William Green, sends his regards and regrets. Bill was unable to join us, unfortunately, but joins me in welcoming you to Thayer for this event. So, John, Michael,
thank you, Joe.
Thank you. Thanks for a great introduction. Let me ask once more, does anybody not have one of these? Because you'll probably want one later on. And can everybody hear me, or is there anybody who would like a hearing assist device? If you do, raise your hand. Okay. Let's see if our slides will come back up. So, as Dean Helbley mentioned, I've had the luxury and the opportunity and the joy of working with my colleague, Dr. Michael Mayer, since he was on my thesis committee sometime prior to 1980. And for the last 30 years, he and I have collaborated. And it was his drive that started an implant retrieval program. Much of what you're going to see today is a result of it. This is a relatively, it's about a year-old picture of our research group. A little bit closer, you can see and get some names. Luckily, I have now still 1 husband-wife team. I had 3 husband-wife teams about mid-1990s, but Barb and John, who are back in the corner there, my husband-wife team. We also have Caitlin, who's back there. Number of students, both undergrads and grads. Most of our research is driven by students, and I'll talk about that a little later. Here's how our program works. We focus on implant retrievals, and that differentiates us from most other places. And so we have collaboration with a large number of surgeons who routinely send us devices, and we have a formal evaluation process for them where we go through, Dr. Mayer evaluates them and photographs them, and then we begin some engineering analysis of them. Once we get information, we take that and make it available back to the surgeons who send us the devices, the manufacturers who make the devices, and then present it publicly, both in forums and in publications, to the surgeons. And I recognize a few of you in here. And as I said before, the research, the bulk of it really is carried out by a combination of both undergrads and grads, and we start as young as freshmen. So we have a WISP program, Women in Science program. Caitlin in our lab actually guides that now, and we had 2 WISP interns this year, and that's pretty routine for us. So these are freshmen in their winter and spring terms who spend 2 terms with us. We now have about 10,000 hip and knee retrievals. What's interesting is how small a number that is compared to what's coming out. So almost 1 million implants are going in the U.S. every year between hips and knees. And about 100,000 of those are revisions. So something didn't work out and they've gone in to do a revision. So in a case of a revision, you have 100,000 devices coming out. We're open to getting as many as we can. We ask for them, and we get less than 1,000. We're typically down around half of that. And when you add all of the other labs doing this, and there aren't that many, it probably doesn't add up to 1,000 total. So this whole idea about healthcare and how you're going to improve it and trying to set up a registry of implants and trying to improve our understanding, part of that would be trying to increase the captive audience here of these implants that are going in the U.S. and being taken out to the U.S. We're funded, and I guess for purposes of clarity, a good chunk of our funding comes from Johnson & Johnson. They don't get a better view, really, of the data that comes from it than anybody else, but we also do research for Johnson & Johnson that parallels what we do with the implant retrieval program. But because they're willing to put money into this and have every year since 1980, we can do all of the work that we do for the surgeons for free. So there's no cost to a surgeon or patient for what we do. So how did we start up? My doctoral thesis was focused at implant loosening. So typically a total hip would go in, work until the patient began to get active, and then often it would loosen up. And so how do you deal with that? Well, I happen to be in the field of cobalt-based metallurgy because I was working for a thesis advisor, George Collier here, who mentored me in that. It turns out that it's the same alloy you make a total hip out of. And there's a hip going around and a knee going around. There are actually 2 hips. The heavy one is cobalt-based alloy. The light one's titanium. So the cobalt hip was the focus of what I was working on. You'll notice on one of those hips, there's a porous structure. That's a beaded structure. And that's actually what we developed here. With Dr. Mayer's assistance, we actually did animal surgery, and then he was one of the first 5 surgeons in the country to put these in patients. This is before the FDA got really involved in it. So these were going into patients prior to the 1980 FDA medical device legislation. So Dr. Mayer was putting these in patients as early as 77, 78. So that was where we started. We wanted to increase our success. We started in getting fixation. We looked at hydroxyapatite coatings. Then we started wondering why some of the knees out there failed, and that really got us into the area of polyethylene. And we started really studying polyethylene when the Couriers came to join us. John was a former student of mine. He had been with his wife in the oil fields, decided he'd like to come back for a reunion. So we chatted about it, and he was disenchanted with his job, and my research engineer just quit to tour around the world with his new wife. And I said, why don't you come and work with us? And he thought I was kidding. And I said, no, I'm serious. He said, but you have to realize it's a husband-wife team. I'm going to bring my wife. I said, all right, what's your wife do? She's a chemical engineer. I said, that's perfect. We need a chemical engineer. So that was 95, and it's worked great since then. And I think they felt a little more comfortable coming into a place that had other husband-wife teams. So we really did a lot of time sharing, and it's been successful for us. But our focus, which we thought was going to be a year or 2 on why knees fail and why polyethylene deteriorates in the body, is something we're still working on. So the last slide today will actually start talking about what we're doing with polyethylene. We've also looked at why ceramic on ceramic hips squeak, and that's been a focus of John Courier's time. We've looked at metal on metal and ion release, trying to understand what's going on there. A lot of that total knee work in polyethylene was done by Caitlin and some of our other students. Caitlin graduated from our program a year ago and was looking for a job and started talking about things she'd like to do. And I said, would you like to work with us? And she agreed, and so that's been a real boon for us as well. And so that this whole focus down here on why new polyethylene oxidizes, which it really shouldn't, is something that she and Barbara Currier have been looking at. And then mobile bearing knees. It's put out as a new idea, and I would suggest that it isn't really. Because the historical approach to orthopedics has been that somebody comes up with a new design or a material, often a surgeon. It goes to a company that does a little bit of lab testing. It goes out and that really gets clinical testing in the patient. So the patient is the guinea pig. There's some failures. You tend to take a sort of cursory look for the failures. And that opportunity to really understand what's going on is lost. And so for 99,000 out of the 100,000 implants coming out, they're not going to a lab that really spends time looking at the analysis of them. Our approach is a little different. So we're working with companies that do come up with new designs and materials, but they also do detailed lab testing. We're actually involved. We share data back and forth with some of the companies. They then get into a clinical application where there's revisions. We look at what's coming out in our implant retrieval analysis program and try to understand more about what's going on from detailed mechanical and chemical analysis as well as a detailed evaluation. So one of the things we thought we would do this morning is see how the information in the sort of literature has gotten to you through watching ads on TV and watching shows, and how you may be dealing with the questions of joint replacement. So I'm going to turn it over to Dr. Mayer, and he'll ask you some questions, and I'll try to use these devices to do polling. So the buttons you're going to use are the ones across the top, 1, 2, 3, or the one down, one step from that, 4. So the questions you're going to be asked will have choices of 1, 2, 3, or 4, and you pick the one that most closely represents your view. So let me turn this over to you, and we'll try this.
So this is a modification of the direct-to-consumer advertising initiative, and we're going to try to find out what's on your mind. We suspect that some of you may have a more personal involvement in the issues that we're describing here. So in a moment, we'll give you an opportunity to register your circumstance here in relationship to your own or your closely related fellowship in regard to joints that you're getting familiar with. So if you could look at the 5 issues that we put up here, you can respond that you've already had a joint, that you might someday, even someday soon, that it's on the books, or that you wouldn't consider it in any circumstance. So we're going to open up the system so that you can register your
So now if you click something that's between 1 and 5, 1 being already had it and 5 being no way, we'll collect your responses. So we've got 26, 29, 30. You can see up there in the top right how we're gauging your responses. Has anybody played with these before? Yeah, you have?
There's one.
All right. I'm counting 42 here. Anybody else? Let's see what we've got for information. A lot of maybe some days, and a quarter of you already had it.
Only a few recoil at the idea. So in a sense, that's encouraging and not too surprising. That already we've penetrated the market in terms of willingness to consider. So the question then comes up, if you have one done, how long do you think it should be around and working on your behalf?
Hip or knee.
Hip or knee?
No, this is a hip. We're gonna do knee next.
Is the question how long do you think it should, or how long do you think it's?
How, in your mind, how durable do you think this joint is likely to be?
Likely. If you did it today.
Right. Yep. If you did it today, is your expectation that it's going to go 5 years or 10 or?
Of course, that begs the question of how long you're going to go.
We're not getting as many responses for you out of this one. Only 30 of you want to really give us the answer. All right, let's see. Out of the 30 of you who answered, what do we get?
So there are some true optimists in the crowd. I think most people are pretty realistic. The 10 and 20 year expectation is not uncommon. The psychology of the surgery is interesting, that if people are queried about how satisfied they were that they decided to have a joint put in and they've faced the necessity of having it revised, if it lasted for at least 10 years, most people will say they did the right thing 10 years or more ago. We are working to get 20 years and more in the research effort that we're making in the lab.
Do you take questions from the floor?
Sure.
Sure.
Let's say you're 60 or 70.
Yep.
And you get a hip in and you expect 20 years. By the time it needs a replacement, isn't it hard to do surgery at 90? What I'm thinking is, when you take the age of the person that's likely to need a new hip, shouldn't it last until they're cremated?
Right. Right.
After retrieval, cremated.
Right. We have a new we have a new system that recovers the joints without cremation intact. So we're not planning to use them again necessarily. You know, it raises the interesting question: is 90 the new 60? And the other good news is that when these joints do get into trouble, we don't usually have to shoot the person who's in trouble. Yes, it's obviously more risky. It's more risky simply because it's a second operation on that joint. So there are inherent changes in the local tissues and so forth that make complications a little bit more prominent when you have to have one redone. It's still a better than 80% likelihood that the replacement revision will work for the foreseeable future. And techniques are always improving, so you can hope that by the time a 90-year-old has to have a 20-year-old joint replaced, the refinements in surgery will be significant in addition to other considerations that come up.
Do you find the durability as a function of the person's level of activity? I would think someone that went early, let's say 60, would be considerably more active than someone that had one put in at 80. In terms of the number of steps they take, the amount of physical activity.
But it's sobering to look at the spectrum. A relatively inactive person is going to take somewhere close to 1 million steps a year. A really active person may clock 4 million steps a year. And some of them may be ballistic. Those do have an effect. And we're trying to make sure that the materials are designed and fabricated in such a way that they can put up with at least some of that extra activity.
Well, let's ask you, do you have any data that examines that phenomenon of the active person versus the elderly who's maybe not so active in your retrieved joints? And what do they look like?
Not as much as we'd like, which is why if you had a better database, you could do better. And that's what this National Implant Registry would tend to do for you. Let's try this one. How long will a total knee last? Do you think it's about the same?
We're going from the hip to the knee now. What are your impressions about the knee as a technology for replacing? We've got more opinions this time.
We're almost, all right, we got all 42. More people are interested. All right. Let's see what we got.
So they're a little more pessimistic, a little more skeptical that the knee will hold up as well. It's probably appropriate in some respects because the knee is a more complex joint and is required to do lots of different things beyond what the hip is, ball and socket, a little more straightforward. And again, we'd like to move the equation beyond a 20-year durability for the knee if we can achieve the materials and design improvements that we hope to.
Question. You said that there's reasons why you would expect the knee to not last as long as it did. What is your actual experience?
The actual experience is the opposite.
That's what I thought.
The knees are actually doing better than hips in a general sense. And we were surprised because when knees were first introduced in 1972, within 5 years you could buy and insert more than 200 different designs. which says that this needs more thought. And since then, the convergent evolution in knee design has been striking, so that now they look remarkably like each other in large part. But it's also true that they are performing remarkably well.
Question on the hip replacements. What kind of data do you have on the success of doing it anterior versus posterior?
They're basically related to complications that come up. And the posterior approach, in its initial application, resulted in more dislocations with the hip going out the back. The anterior approach has evolved significantly, so that now some surgeons are making a very small groin incision and getting the hip put in that way. The problem that comes up with these incisional decisions is that you're basically looking for a short-term gain, a benefit of recovery, which includes the first 3 months, but you may be compromising the 20-year durability that you're looking for. So it may be an inappropriate trade-off. There's a lot of hype, a lot of commercial spin being put on the whole issue of, gee, you can walk from the operating room back to your hospital bed. Don't count on it, and I wouldn't put a lot of benefit accrued on that claim. So there's a lot of settling out that has to be done. Some of the registries that are already in place in Sweden and Norway and Australia are beginning to get good hard answers to contemporary questions like that. But they still have to be parsed further than they have been yet.
Can you just address resurfacing versus replacement?
We'll get into that a little bit later in the presentation. It's a very real concern, and it seems that it should be more conservative to replace the surface than to replace the whole structure. That may not be an appropriate assumption to make.
In terms of your comparison of the expectation on a total hip, what about a partial hip? Are those lasting a lot less or about the same?
Well, by partial hip, I'm going to assume that you mean just replacing the ball and having the ball function against the socket. That's an old technology that's been around for decades. That was one of the earliest artificial prosthetic interventions that hip surgery offered. The problem has to do with how happy the cartilage in the socket is going to be with that metal ball to articulate against. And generally speaking, it's reserved for the less active, more senior patient in the population whose demands are going to be modest.
So the length of expectation on that before you have to do a total would be what?
Well, the statistics suggest that if you have a patient that could be operated on and just get a partial replacement versus going ahead and doing a total replacement, the durability of the total replacement is better. So the likelihood of a second operation is smaller if you do the socket and the ball at that first sitting.
We'll talk a little bit about why, with new materials, that equation has changed. So here's your next question.
So where do you go once you get that new joint?
And it's either one, either hips or knees.
Hip or knee? Are you just going to walk sedately around the community? You're going to throw yourself into the pool, drag out your bike, play squash, or compete, and compete hard?
You can ask that one. I left that out of the slide.
So it's a reasonable spectrum. Nobody thinks that simple walking is going to suffice to satisfy anybody. Most people would go a little further than just the pool. And some people even have the optimism that they would throw themselves into vigorous competition. The question is, what are you burning in the process of going that hard? My suggestions to the patients that I was managing was that there are some specific things that they need to avoid. One of them is jumping off the third rung of the ladder and landing with a crash. And the other, sometimes jumping off a tractor comes to the same thing. But and patients should be advised to approach the question of lugging something really heavy that they can't walk gracefully when they're carrying it, and especially up and down stairs or slopes. Beyond that, people asked whether skiing was a reasonable activity. I don't remember any patient who had to come to revision because of their decision to go skiing. Many of the people who decide to go skiing are pretty good at it. And so skiing is a pretty graceful activity for many of those people in this part of the country anyway.
And one of our recipients of a total knee ending up fourth in the worlds in the squash championship. So our former squash coach here.
In a senior league.
Senior edition. So it's doable. What do you think about triathlons and running?
Well, it's a harsh activity, and I would generally suggest that people who want their knees to last for 20 years should shy away from that kind of ballistic commitment.
But the swimming part.
Swimming part should be well tolerated.
And the bike part.
And the
so
bike
you got to
part
find a
should be okay.
triathlon that doesn't force you to run.
There's a third sport that we haven't defined in there.
Wouldn't squash be more difficult on the joints than running?
It depends on how hard you play and who you're playing against, I think. Generally speaking, people seem to have tolerated squash and racquetball pretty well. Tennis also, especially on clay, where you don't harshly jam yourself to stop or change direction.
How about lateral movements?
Well, it's more of a challenge for the knee, but if the ligaments are sound and the muscles are fit, that should be tolerable. It's a trade-off.
Doesn't the forces imposed by biking or playing squash comparable to forces imposed by carrying the luggage?
Well, the joint mechanics suggest that any burden you put on a knee or a hip results in a 3 or 4 factor increase in the total that the joint has to sustain. So climbing stairs will put 3 or 4 times body weight force on your hip or your knee. If you carry a 30-pound bag, that's an extra 90 to 100 pounds on your joint. Going ballistic, playing jungle ball under the basket, results in forces that exceed 6 or 7 times body weight. So yes, there are very clear variables that you will invoke when you decide to do that.
The question about the knee and torsion, the reason we sent around a fixed bearing knee and then this, which is the mobile bearing knee, is the concern with the fixed bearing knee is if you torque it, and that is twist hard, you may put enough force between the implant that goes in your tibia and the bone that you could shear that. And the point of a knee like this that flexes, which is what the squash player has, is that there's nothing to stop the bearing from spinning. So the bearing can spin around. And so it's only your ligaments that resist that.
I was surprised on that one is how far the upper and bottom plates go into the bone.
It's a revision component. So this is yours first failed, or maybe your first and second failed. And so they give you long stems.
When it comes to the living health of the bones, to have something that far up into the center bone.
Yeah, the bone tolerates that remarkably well. Actually, the bone that is bridged by the metal realizes that it has little to do and tends to go away. Not to the point of causing it to fail, but it will diminish the robust character of the bone that is no longer being loaded the way it used to be. So we don't put in a big, long stem like that when we first do a knee replacement.
Right, so there's another mobile bearing around that has no stems on it, which is what you would get as a primary. Okay, another question.
So here, the question is, who makes the choice that you might be exposed to when the surgery is actually done? Is your surgeon the one who's going to choose, your hospital, where you have it done, the reputation of the center or the surgeon himself or herself, or other peers in your community, people who are happy to give you advice, whether to deserve it or not?
So try that one. So it can be any reputation. Reputation of the surgeon, reputation of the hospital, or whatever. All right, let's see what we got.
So I'm happy to see that result. And obviously, reputation is a fairly broad question, as John pointed out. It could be the reputation of any of the involved issues. But relatively little influence from your friends and relatives and members of the community.
One of the things I was thinking of doing, and this was the 7th time I put these slides together because I had trouble with this system. I was going to put in the device, and I was going to be interested to see what people would say about device as opposed to anything else.
See if that direct consumer advertising has had an effect.
Yep.
I've had the last 6 years the right knee replaced and the right hip twice. And it's difficult, well, it seemed difficult to do research on who, when, where, and how. And I set about doing that. And here's what I would suggest, because there seem to be a number of people in the audience who are thinking about it. Relative to the doctor, find out how many he's done, and if he's willing to give you 4 patients he's done on your age, that they will take a call. Now, the doctor that did mine as post-knee surgery asked a number of patients, will you take a call or an email from a person who is about to do the same thing? And I found that helpful. The other thing relative to the hospital, find out how much staph infection or that they have, and you can get that if you do enough research. The other thing that I noticed, we talked about a little bit, that hadn't been talked about much, was what kind and how much rehab. I had the good fortune of being, when I sold my business, being associated with an NFL team for 2.5 years. And the doctor who did my knee, I did, the day he did mine, he did 2 other people, both women, one significantly overweight who flew to Houston from Germany. And we were in rehab together for about 3 weeks. She complained she wasn't getting any better, but she wasn't doing the work either.
Yeah.
And in the knee replacement, it seems to me that the first 6 weeks and how much and what therapy you do is significantly important to how well you get quickly, or how quickly you get well, how quickly.
I think it's true.
And the hip, I found that it was a piece of cake relative to the knee, but that I wanted to do some things so that the rehab and the type of rehab and how much, particularly for the first 3 months, was significantly important.
It controls things. Let's go on. Let's just do that. We'll come back to that. But let's go on to developments, because we didn't really talk about devices. And one of the things that we find is that many of the implants that are taken out fail because of reasons internal to the implant. So you don't need to necessarily have an infection or a malposition or some kind of trauma event to have your device fail. And these are described as new devices as you look at the literature: metal-on-metal hips, ceramic-on-ceramic hips, mobile-bearing knees, and cross-link poly. And what you're going to find, if you really study this, is we actually have a history of these things. So this is the new metal-on-metal hip that was made available within the last 10 years, and there are new editions of it within the last 5 years. These are hips out of the 70s, this one and this one. And so we've done metal-on-metal, and we actually have a pretty good handle on what goes on with metal-on-metal devices. There are some real benefits in the sense that you don't have a piece of polyethylene in there which can wear and generate debris, which sometimes causes a cellular response and causes bone to go away, so you have to take it out. But there are some other trade-offs that you have to deal with when you have metal-on-metal. When you have modular components, you have interfaces between them, and we find corrosion, and not uncommonly. And one of the problems with metal-on-metal devices is that this, which is a titanium stem and a cobalt head, is something that we learned how to deal with by making this cobalt head more and more homogeneous, which meant making it softer and softer. But it was articulating against polyethylene, and that was okay in the early days. When you go to metal on metal, soft metal against soft metal doesn't work. Soft metal against hard metal doesn't work. Hard metal against hard metal does work. So you now have to have really hard cobalt chrome heads. And they're not particularly corrosion resistant. So when Dr. Mayer suggested that when you look at a surface replacement, it's not all pudding. What he meant in part was that the average of these surface replacements are very large diameter metal heads and metal cups. And not everything that we see about metal on metal is ideal. Here's corrosion on the outside of a cup. Here's one on the trunnion of the stem, and here's some inside the head. So you say, is that a problem? Is it going to fail? Is it going to break? No, it isn't. But it's dumping ions in your body. And it's clearly the case in some patients that a certain number of ions causes tissue responses on the one side, but systemic responses on the other. You might want to say something about some recent patients.
We're only just beginning to realize what are the systemic consequences. It's been posited that maybe ions of cobalt and chromium in your bloodstream might result in a malignant growth developing somewhere in your body. That appears not to be a major concern, but there are other things that can happen which are undesirable. We had a colleague in Alaska who pushed a metal on metal really hard by biking thousands of miles a year. He was an orthopedic surgeon who had to stop practicing because his peripheral vision began to diminish, his hearing began to fail, he began to forget things that he needed to remember, and he began to develop a severe tremor. His hip was revised to a polyethylene component in the socket, and most of those symptoms have receded, so he's back practicing again. But that raises the issue of what are more subtle expressions of this kind of cobalt distribution in your body.
So hard-on-hard bearings, when they're metal, for some subset of patients whom we can't identify preoperatively, can give you really undesirable responses. Ceramic on ceramic is something that's been touted as something new. Remember when Jack Nicklaus got his ceramic on ceramic head? A good friend of mine, Ben Bierbaum, did that surgery in Boston. But here's an autophore, which is ceramic on ceramic from the late 70s, early 80s. Notice that it cracked because of the range of motion had the neck of the component hitting the cup. Here are some more recent ceramic on ceramics that show us different ways of getting in trouble. And interestingly enough, here's a very recent ceramic on ceramic where we got into trouble because we hit the rim of the cup with the neck of the implant. So we learn slowly on some of these things. Excuse me? With the neck of the hip, so range of motion, because the cup wasn't put in quite exactly perhaps where it might have been. This is something that John Collier is studying. If you listen to enough patients who have ceramic hips, some of them will squeak. And the question is, why do you squeak? And the squeak expert's sitting back there, and he's not saying right now, but he can reproduce this in the lab. So if you have interest in squeaking hips, grab John just afterwards. Why are we so concerned about ceramics and the possibility of them breaking? If a polyethylene component breaks, you take out the pieces and you put in a new one and your prognosis is good. If you have ions from a metal hip and you pull it all the tissue that's affected out and get out as much metal debris as you can, it seems that you've done yourself reasonably well. If you have a ceramic component that's broken for one reason or another, the debris of the ceramic remains. You can't get it all out. And so this is a hip that was following a failed ceramic component. This is the polyethylene cup that was put in. This is the metal head that was put in. This is how it looked the day it went in. And this is how it looked 18 months later. And the problem is the ceramic debris ends up sitting right into the polyethylene cup and getting embedded just like sandpaper, and you just ground it. Not an ideal circumstance. How about the knee? This is how many early knees failed. They failed because the polyethylene gave up. All of the bearings for both hip and knee that are out of a polymer are out of ultra-high molecular weight polyethylene. And what happens is that this material is affected, and one of the things that Barb and John were involved with in the early days, along with Dr. Mayer, was trying to figure out why these things failed, and it turns out the way they're sterilized. sterilized. I won't go into that, but it's radiation hits these things to sterilize them. It starts a chain reaction, and the material breaks down, whether it's sitting on the shelf or in the body. And this is how fast it breaks down. So this is taking a whole bunch of components and looking at their mechanical properties as a function of time. And we get pretty close to 0 out here, pretty close to 10 years. So if you think back where you were saying, what's my expectation for a hip or what's my expectation for a knee? In large part, it's anecdotal, hearing about patients whose hips or knees have deteriorated, often in the hip because of wear, often in the knee because of failure. And this is what was going on with the material. So you can't isolate everything that's going just to the surgeon, just to the patient, just to the activity. If your material's going downhill, you're in trouble. So one of the things we've spent a lot of our time on is how do you improve that? One of the other things that goes on in hips is it turns out the articulation, in knees, the articulation in the knee doesn't generate a lot of wear, but the motion of the polyethylene against the tray that it's sitting against does. Another thought about that mobile bearing, it's 2 polished surfaces. What you'll see in that fixed bearing that's around is they've now changed the fixed bearing knees so that surface is polished as well. There's one of these going around. And what they've done is polish the tray so that while that fixed bearing's supposed to sit there and not move, whatever movement it does have doesn't generate a lot of debris. In that rotating platform, the articular surfaces tend to show a little bit of scratching, but not a whole lot of wear. One of the things that our papers over the last couple of years have focused on is how much wear is there in these rotating platforms, because you do get scratches in the back. And the scratches turn out to be a function, apparently, of third-body debris. Mostly the bone cement that's used to fix these components gets between the polyethylene and the metal tray, and as you move, it scratches. And so one of the things that folks in our lab are trying to look at is why do the scratches have such a 33 RPM? You'll all remember 33 RPM records. I say that to the students and they go, what's a 33 RPM record? So all these scratches. But as time goes on, you get out to longer periods of time, you tend to burnish those out. And they don't seem to generate a whole lot of wear. This is a study that John did that looked at wear rates. And what's interesting is this is how fast it's wearing every year. And this is the year in which the implant was taken out, whether it was in there for 8 years or 9 years or 10 years. What you see is that as time goes on, the wear rate, that is how much wear we see divided by year, actually tends to either be stable or slightly going up. Not too surprising because the polyethylene's moving in the tray. The mechanical properties of the polyethylene are going down. If we look at the same data for the mobile bearing knees, what you see is the longer it's in, the less wear you get. So it actually beds in. So the mobile bearing is talked about as a new design. We started working with this with the surgeon who developed it because we put the porous coating on it in 1980. So it's not a new design. People are starting to hear about it, but there are a whole lot of people who've had these components in for 30 years. So, and finally, the last thing that we're spending a lot of time is trying to understand why the polyethylene bearings oxidize. There's a whole line of new materials out there you may have heard of called cross-link materials. Do they produce better wear, and what are the trade-offs? This, again, is that problem of oxidation over time. And so what it says is increased oxidation occurs both in components that sat on the shelf and components that were in the body. There was sort of this hope that maybe in the body things wouldn't oxidize as fast, and it turns out, oh, they oxidize fast. When you get oxidation, the mechanical properties go way down. You can fatigue fail these. So people are talking now about cross-linking. And so the question that we get into and the way our lab works is let's get all the cross-link materials and evaluate them and see if the expectations should be the same for them all. Certainly the marketing advertisements would say they're all going to be sensational. They're all sterilized, they're all cross-linked by radiation. That generates this chain reaction in the polyethylene. And so one of the things they're trying to do with the cross-link materials is get rid of that one way or another. But here's the desire. Here's why folks want cross-link material. And that is that the wear rates dramatically decrease as the amount of cross-linking increases. So we'll only look at one. We'll look at hips. Hit with a 5 megarad dose of radiation, wear rate's supposed to be down in a simulator by 90%. 10 megarads, it should be down by 99%. We now have data from series of patients. If you don't radiate it, the average of the wear that you get is at about 0.2 millimeters a year. So 10 years out, you've got 2 millimeters of wear. mean, we're talking thick. New materials, cross-link materials, wear rate is 0.01. So your expectation of what you can do with a hip now is a lot greater than it would be if you got a hip prior to 1998 in terms of wear. And so you can afford to be active, which is why we're sort of encouraged about these changes. If we look at a whole series of these, we only have 65, they show very little wear. However, there are some mechanical changes if you don't do the cross-linking in an optimal manner that tend to reduce the mechanical properties. So some of these things have cracked. So surgeon is still real critical. Positioning of the device is still real critical. What kind of activity you're doing is critical. Don't worry about the names on here. These are all commercial manufacturers. But remember we talked about higher dose gives you better wear resistance. Higher dose coming out this way, this is 10 megarads, this is 5 megarads, gives you lower toughness, so it's not as strong. So just like everything else in life, there's a trade-off. How much wear resistance do you want versus how strong do you want your material? We're fighting against that in ways that say, let's make new materials that are better. These are techniques that the companies are using to deal with free radicals. Here are the trade-offs. Basically, an annealing trade-off gets rid of a bunch of the free radicals and maintains the toughness, but doesn't get rid of all the free radicals, so it does oxidize in the body. This technique, which is used by some other manufacturers, gets rid of the free radicals, but it's less tough. This is the newest technology, which we don't know as much about, but it looks like maybe that takes care of some of the trade-offs. If we look at these free radicals that get us into trouble later on, here are all the commercially available materials. Here's one of the cross-link materials. So we remember we said the gamma and air and barrier package, these sterilized components were a problem. Well, here's the free radicals they had. This is a new modern material. It's got a lot more. It's going to oxidize a lot faster. These are all the remelted materials. They have no free radicals at all. So, but it's going to be very hard for you to find that out just reading the literature. We now have retrievals. These are how fast we saw oxidation, remember, in just gamma sterilized components. These are those new cross-link components that were annealed rather than being remelted or using antioxidants. One manufacturer does this. Get much higher oxidation, much shorter periods of time. It's hard to call that an improvement. One of the things we try to do is do accelerated aging, so we can try to find out in the lab and do some prediction. I won't go into this, but we do a lot of trying to understand what's going on in these components, how they change over time. One of the things we recently bumped into, remember we talked about some of these remelted materials are great because there are no free radicals, and we feel great about that. and so when we look over here, this is the one that has lots of free radicals. These materials have none. And so you sleep well at night, which is appealing. And if we shelf age these components, what we find is they don't oxidize at all. So sitting on the shelf, they don't oxidize. So we still sleep well at night. So we feel real good about that. This gives us a little pause for concern. These are retrievals. Remember we said we had 65? We actually see some measurable oxidation in some of these. But there are no free radicals. So if you want to know why we stay awake at night and are trying to always figure out how we can make better materials, it's that slide. So sitting on the shelf, these materials don't oxidize. All the stuff that was gamma air, gamma barrier, all the traditional stuff, if you leave it on the shelf long enough, oxidizes and turns to dust. This doesn't. That's great. Until you put it in a human. And then the humans tend to chew it up some. I mean, it may have something to do with diet. So this is the last slide. Our strategy then, we focus on retrievals to understand what we're doing. We do a lot of research to try to move ahead and develop new technologies for testing devices, for analyzing devices. We actually have a program ongoing with one of our faculty, Doug Van Sitters. He's developing new materials. And then we spend a lot of our time teaching. So the whole focus of our research lab is teaching. And we have a number of undergraduates. We've got undergraduates that transfer to being graduates. Steve Reinitz is back there. He was an undergraduate doing great things in our lab and then applied for the Innovation PhD, and he's now in that program. And he'll be working in this area, trying to develop new bearing materials. And so when you come back for your next reunion in 10 years, Steve will be your keynote speaker telling you how he solved all the problems associated with wear. So thank you very much. We'll be happy to answer any more questions if you have them.
So I was very young when I had my knee replacement, 10 years ago. And I'm so depressed now. What are the chances? I mean, I'm inevitably going to have, I'll be telling my doctor to send it to you in the next 10 years.
In the interest of full disclosure, I'm walking around on a rotating platform, total knee on this side. And when you look at the numbers, the 10-year data suggests that for the knee that was put in 10 years ago, more than 90% of the people with those knees are doing fine. 20 years, more than 80% of the people.
Really? Oh, good.
So.
All right. Thank you.
I'm a pathologist, and I was struck by when one turns out, and this actually refers to your last slide, about oxidation radical. And did, this is sort of a retrieval thing, post-mortem on a man that an eminent orthopedist had done a couple of failed, actually 3 failed hips, and then the man also had multiple post-operative dislocations. And he turned out to have, he was 89, but he turned out to have hemochromatosis. And the surgeon's response was not, should have got that, but it's good, it wasn't my fault. And I think that looking at the tissue strength and the engineering of the tissues around, which I guess is sort of my world rather than yours, probably should be folded into this retrieval study.
Absolutely.
Yeah, we're working very hard locally and nationally to try to promote that interaction, that cooperative.
When we were working on porous-coated devices, we did histology routinely. I had 4 people working 40 hours a week sectioning implants and looking at tissue ingrowth and such. Having that technology pretty well accepted and out there looking at the bearings, we really focused on the polyethylene itself and aren't doing histologies, but we are trying to collaborate with folks who are.
And it does appear that there's a very real and unique individual difference in reactivity in patients to both the polyethylene particles. Some people seem to tolerate fairly large burdens of polyethylene particles and not react very aggressively to them. Other people seem to dissolve a lot of bone with a relatively small burden. Metal is even more complicated because it appears that the ions that are released into the tissues actually modify the shape of the proteins when they complex with the ions, and turns the complex of ion and protein into an allergen and creates an immune response to that combination. If we could find a way to test people in advance of their surgery so that we'd be able to tell people, gee, don't worry about it, you're fine, you aren't going to react, or hey, there's a problem here that you may want to approach differently. Until we can get those kind of preoperative tests designed and ratified, we're stuck sort of hoping that people will be okay and following everybody after their surgery.
If I may burden you with a follow-up, I think that the place to look for that is in pediatric joint and other prostheses, because the people who get them have a variety of fairly well-characterized genetic little boys, particularly to get them, have a variety of fairly well characterized connective tissue defects. That might be a place to start.
20 years ago, the big concern was so-called cement disease in orthopedics. The cement felt to be the cause. Putting the implants hold up, be causing bone dissolution, but then you realized that it's actually polyethylene. What were the key observations that changed the thinking from rather than cement disease to polyethylene wear?
Ton of studies, animal studies, actually cell culture studies to try to figure out what stimulated cells to release prostaglandins, interleukins and generate this cascade that cause bone to go away.
That and the development of uncemented implants put in without cement that developed osteolysis. And so there clearly had to be another factor. I don't think...
key aha moment, or just a whole series of studies?
Just a gradual evolution of insight. I think the cement debris does cause osteolysis, but so does the polyethylene debris. So both of them contribute to the reaction that results in bone destruction.
Yeah.
Polyethylene seems to be a constant here. What about other plastic materials?
Played with a lot. What you're really trying to do is get something that's tremendously wear resistant and tremendously tough. And polyethylene really sort of pegs the meter on both of those. And there are a zillion ways to fabricate polyethylene to improve its properties for orthopedics. I mean, historically, this stuff was bought by the railroad car load, and somebody ram extruded it, and bars showed up at your place, and you made implants out of it. And it's only recently that people are now really focused on how do you make it, how do you treat it, how do you pre-process it and post-process it. And so it's a great material to start with, and you can dramatically tailor it to what you're trying to do, which is what Steve and Doug Van Sitters are really focused on.
All the data you have comes from failed joints. And then you conclude from this onto the performance. Wouldn't you really need autopsy information from non-failed units to give you the proper information?
Certainly, we've worked hard to get postmortems from time to time, and Dr. Mayer will talk about that. A lot of the implants that come out don't come from failure of the implant, but come from things like infection. So we do get a pretty broad spectrum of implants that didn't mechanically or materially fail, but are no longer being used because the patient had a reaction to it or an infection from it. You want to talk about the cadavers?
Collaborated with the anatomy department here at Dartmouth Medical School. So I have the deaner who manages the donor specimens to survey the field and let me know where a specific cadaver has a joint replacement component that I can go and get. But it's a very labor-intensive process. And to do it on a wide population of people who've expressed that commitment themselves before they died represents a really challenging issue. Some programs have done that. They've maintained little crash carts and a resident or a fellow who rushes out in the middle of the night with a bag of tools and goes and gets it. As I say, really labor-intensive and not clearly sufficiently valuable to warrant the extra effort.
In a nutshell, can you just reiterate the difference between resurfacing
Resurfacing, typically, what you do is you cut the cartilage layer off the femoral side, and you slip a metal cap over that surface. So that is the resurfacing side. On the acetabular side, you don't want to articulate this against whatever cartilage is left, so you actually put in a socket, which is typically metal. And some of them are one piece, so they're metal porous coated on the outside and smooth metal on the inside to articulate against this metal head. And some of them are modular, so there's a metal insert in there that could at some point be replaced with a polyethylene insert if you so chose. But there's no stem on the femoral component. And so you don't actually cut the neck off the femur in order to put the surface replacement on. So from that standpoint, it's more conservative on the femoral side. It's not more conservative on the acetabular side, and in fact can be more aggressive on the acetabular side because the head has to be pretty big. And the vast majority of these things are metal on metal, so you have the potential for metal ion release if you don't anyway, and it can be more rapid if your alignment isn't perfect. Did I miss anything?
Yeah, and resurfacing relies on the health of the bone of the femoral head, both before and after you resurface it. A number of the revisions that had to be done and converted to a standard replacement technology failed because the bone under the cap that was put on the femoral head resorbed and caused the resurfacing component to loosen. And that's a technique issue, but it's also something that probably can't be completely avoided.
Seems like the audience is composed of doctors. Done it like this lady and me are wannabes. And what I'm going to say is kind of addressed to the wannabes. The question is, you know, when do you have the knee and the hip replaced? My doctor who did one knee and said, and I think this is right, when it hurts like hell. And on the hip, in my case, I fell. So that was the other thing. I think there's a, particularly in the knee, when you're rehabbing, ice versus drugs. I found that I got off the drugs quickly, and when I had some pain, I had one of these little things, a Velcro
The
thing
cuff,
with
yep.
an ice thing, and it worked just as well as a drug. And lastly, there's a study going on at Baylor College of Medicine in Houston that is a urological study about testosterone replacement in men, but they also found as a side effect that healing from arthroscopic surgery is significantly improved both in men and women with this testosterone replacement. I don't know whether that's controversial or not, but it worked for me.
It is controversial. The other observation I would add is that of the 7,000 or 8,000 total joints that I did in the course of my career, almost uniformly, patients would come a year or two later and make the observation that they wondered why they waited so long to get this taken care of.
One last question? Okay.
How do you find out more about this when the time comes without calling you guys?
Why wouldn't you call us? All right. But seriously, we do answer that kind of question routinely. So yes, absolutely. So just email us. And Michael, for years, has run a website. How would you
The
describe
Doctor's In, yeah.
Yep.
All of their information is on the their website, engineering.dartmouth.edu, and you can just search for Collier.
And if you can leave your clickers on the ends of the tables as you go out, that would be great, these things.